The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Thank you for joining me for a few minutes over your lunch hour. I appreciate sharing this time with you. My name is Amie Brooks, and I'm looking forward to about 15 to 20 minutes of talking about one of my favorite topics and talking about some new medication-related updates for 2016 for diabetes. We'll be focusing our time on type 2 diabetes this afternoon, given the limited amount of time that we have and the complexity of treating type 2 and all the new medications that are on the market and in the pipeline. So what hasn't changed much is this algorithm. You may recognize this. This has been published by the American Diabetes Association and the European Association for the Study of Diabetes now for a few years. And it looks pretty similar to what it has. A few things I'd like to point out, though, is that we've heard the words patient-centered for many years as it relates to all types of care of our patients, and it's been a bit of a buzzword or a buzz phrase. In the setting of diabetes, it's really set up very well for patient-centered care. So when we say patient-centered care, we really mean involving the patient in the decision about therapy, which therapy, when to start therapy, and so forth. And with type 2 diabetes, it's kind of the blessing and the curse. The good thing is, once we have started metformin, which is our evidence-based first choice in all patients who don't have a contraindication, and has been so for many years, since the historical UK-PDS 34 trial gave us some limited, but yet still some cardiovascular benefit with its use. We really don't have a lot of evidence-based guidance for the choice of our second-line agent. So in looking at this algorithm from the ADA and EASD, you'll see that as we get past metformin and we're choosing our second-line choice, there's not a lot of guidance. And so it really is a patient-centered approach. So if you look down the left-hand side, the ADA, EASD give us these considerations. There may be additional considerations based on your patient in particular, but we want to think of things like how effective the medication is as it compares to A1C lowering and the A1C of your patient. You want to think about the risk of hypoglycemia and the impact on weight. You want to consider the entire side effect profile, really, and of course the cost. And many of the new medications I'm going to be talking about today are very high cost. So in addition to one labeling update with metformin, our old standby, I'm going to focus the bulk of my time on this group of medications here over on the side. These are our newest medications and those that have had some recent FDA warning updates and have had sort of the most action in the last few years. So I hope that you'll find it effective to focus here. The sulfonylurea class and thiazolidine-dione class really have not had much change in the past 5, even maybe 10 years. I will talk a bit about rosiglitazone as it relates to the setting of cardiovascular risk evaluation of diabetes medications. As you likely recall, rosiglitazone was removed from the market temporarily and then subsequently placed into a REMS program, which has since been removed, following a 2007 meta-analysis that indicated an increase in cardiovascular risk with that medication. The reason I'm talking about that in the context of this webinar is because it really set the stage for what types of evidence we need to be looking at for all new classes of diabetes medications. The FDA now mandates a cardiovascular risk trial be done for every single diabetes medication as it comes to market. And the primary focus of the cardiovascular risk assessment is, does the medication increase cardiovascular risk? But of course, we're also concerned and interested in whether any of the medications can decrease cardiovascular risk because we know that cardiovascular disease continues to be the leading cause of death in our patients with diabetes. And so there is some new data with these classes as it relates to that FDA mandate and those trials that have been conducted. So first, the metformin label changes that the FDA announced just 2 months ago, really. Finally, if you've been in practice for a while, you'll recognize this is really the way that we've been practicing for a number of years. But historically, the product package insert has been labeled that we should not be using metformin in patients with a creatinine clearance of less than 60 mils per minute. And in practice, that was often very difficult. Given metformin's known benefits, we always hoped to be able to use it and attain its benefits in the majority of our patients, and that 60 ml per minute cutoff was pretty tough. So now the FDA has finally updated based on loads and loads of data to say it's safe to do so. And now, instead of being based on a serum creatinine cutoff, we're basing it off of creatinine clearance, which makes sense and is in line with how we dose, most other medications. And their stance is contraindicated when less than 30 mils per minute. Do not initiate in the patient with a clearance between 30 and 45. And then if you have a patient with a clearance between 30 and 45, just reassess the benefit-risk ratio to make sure it makes sense to continue, or not. So that has been a welcome change that I think relaxes some of the medical legal concerns that folks have had for years when actually using metformin in this way. So now getting into these newer classes of medications, I don't know about you, but I see these new medications all the time, and I feel like there's a new one popping up every week, and it's like, what is that one again? And I have to look the medication names up, even in a diabetes-focused practice. So I can imagine if you're in a generalist practice, you feel that way too. So the DPP-4 inhibitor class includes these 4 agents at present, with some more in the pipeline that I'll talk about at the end of the presentation. Januvia being first to the market, and the others entering thereafter. As you likely remember, the mechanism of the DPP-4 inhibitors is to inhibit the enzyme that breaks down our naturally occurring glucagon-like peptide 1, or GLP1. And GLP-1 is good. We want more GLP-1 in our type 2 patients because GLP-1 stimulates insulin release, it inhibits glucagon release, and it slows the rate of absorption from the GI tract of our carbohydrates especially. And so all 3 of those mechanisms of GLP-1 result in a lower level of plasma glucose, which is our goal. So by inhibiting the enzyme, which breaks down our naturally occurring GLP-1, our GLP-1 is allowed to do those beneficial actions for longer. And so we do have some benefit in glycemia as a result of the DPP-4 inhibition. However, the efficacy with these agents is minimal. It's hard to pinpoint the exact A1C reduction to expect, but it's somewhere between 0.5 and 1% for this class in general as it relates to the maximum A1C reduction. However, they are well tolerated. There's a minimal side effect profile. We see very few side effects with these medications. They're pretty easily dosed. Most are once a day. We do have some renal dosing with some of the agents that actually can be beneficial because it can allow you to use the medications down to lower clearance levels. They're weight neutral. Some patients experience a few pounds of weight loss, but it's not generally a very clinically significant weight loss, but not weight gain, as we know the sulfonylureas and TZDs can cause. And finally, a low risk of hypoglycemia. So in looking at the ADA-EASD approach of evaluating medications, the side effect profile is pretty much a positive. Efficacy minimal, though, as stated, and the cost is high. Still all branded medications, still quite expensive, upwards of $200 to $300 a month if a patient is cash pay, or on the healthcare system's dime. So overall, oral, easy dosing, cost-efficacy ratio, though, however, is unfavorable. There's new and emerging data with this class, some as recent as last month. There has been some data emerging since 2013 related to the cardiovascular risk profile of the agents. Again, going back to the FDA mandate that the medications have this type of data on file. And in 2013, 2 different studies were published indicating a finding of increased heart failure hospitalization. Now, both of these studies, one with Liraglutide, the Examine trial, and one with Saxagliptin, the SABRE-TIMI 53 trial, were designed to look at overall cardiovascular outcomes. They were looking at major adverse cardiovascular events, or the MACE outcome that we see a lot now. And of note, there were no significant findings as it relates to an increase in cardiovascular risk of the primary outcomes in these studies. But in both studies, a secondary outcome of heart failure hospitalization did reach statistical significance, and so has been a point of concern of the FDA since that time. In just this month, actually last week, there was an observational study published that looked at over 1.5 million subjects across the world. And in this observational study, they did not look specifically at agents. They didn't look at Liraglutide and Saxagliptin specifically, but they looked at the incretin class overall, so DPP-4 inhibitors and GLP1s, and they did not find an association between those classes and heart failure hospitalization. So I think the jury's kind of still out on this, but we do want to use caution when we're starting these medications in patients with heart failure. An update as of August of 2015, this is from post-marketing surveillance, so not a clinical trial per se, but there have been a growing number of reports of persistent significant joint pain with the use of the DPP-4s, and the mechanism has not been elucidated, but something to keep in mind and to perhaps educate your patients on and to monitor your patients for. The next class I wanted to discuss briefly is the sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. There are 3 currently on the market in this class listed on your screen. And these medications have a unique mechanism of action where they work in the kidney in the proximal convoluted tubule by decreasing the amount of glucose that is reabsorbed into the bloodstream at that site. There are both SGLT1 and SGLT2 transports there, but the SGLT2 is responsible for 90% of glucose reabsorption. By inhibiting that, we in essence cause a significant glucosuria. So we induce glucose loss in the urine. A unique mechanism, which I think is very cool from the scientific perspective. However, what it translates to in clinical practice is a relatively minimal efficacy as far as A1C reduction. Pretty similar to DPP-4s, we see somewhere between 0.5 and 1% A1C reduction. The adverse effect profile is not perfect. We do have some unique adverse effects with this class, including primarily genitourinary tract infections. There is a slight reduction in blood pressure because of the volume reduction, so this can be considered beneficial, but may be also something to monitor in your patients with low blood pressure, where you don't, perhaps want to start this class because of that risk. Overall, a low risk of hypoglycemia and weight neutrality, which is good. A few pounds lost could occur, but not generally clinically significant. Another adverse event that is emerging is ketoacidosis, which I'll talk about on a subsequent slide, and of course is a quite serious side effect of concern. Cost with these agents remains high, still branded newer medications to the market. And so overall, again, we see that unfavorable cost-efficacy ratio. There, in addition, are a few drug interactions to consider. So using this class of medications presents a few different complexities than what we see with some of our other more commonly used classes. The new and emerging data on ketoacidosis is from post-marketing surveillance, and the FDA released a statement in December of 2015 with this warning. The DKA that we're seeing tends to be a bit atypical in that the patient's blood glucose is generally less than 300 milligrams per deciliter, which is not, the common presentation of DKA. There have been some subsequent studies and epidemiologic evaluations which have elucidated some risk factors, though. So we now know to look at patients with long-standing disease that likely have pronounced beta cell failure, prolonged starvation, patients who are on low-carb diets are at high risk after surgery or during illness. So these would be patients that would not be ideal for the SGLT2 inhibitor initiation. A brand new FDA release, actually just this week, on leg and foot amputations It actually came from a clinical trial of canagliflozin, and that is still being evaluated to determine mechanistically the theory behind that, and perhaps if there's any real concern. On a positive note, however, we had the InfraReg outcome study. This is a big deal because this is only now the second study where we've seen cardiovascular benefit with a certain specific class or agent in the study of type 2 diabetes. It was a multi-center RCT, a very well-designed study of type 2 patients with a mean A1C of about 8% at baseline and pre-existing cardiovascular disease. So these were patients at high risk of cardiovascular outcomes. The patients in the study were on standard therapy at baseline, so most of them were on metformin and a good portion were on insulin. And empagliflozin 10, 25, or placebo was added. The duration of the study was about 3 years. The major finding here is the primary composite outcome. This consisted of cardiovascular mortality, non-fatal MI, and non-fatal stroke. And we saw significant clinical or statistical and clinically significant reduction in that composite outcome with the use of empagliflozin as compared to placebo. So this is the combined 10 and 25 milligrams as compared to placebo, with the number needed to treat of 62 patients. We also saw some positive secondary outcomes. Of note, the one I have here on the slide is cardiovascular mortality, which was decreased with a hazard ratio of 0.62 and a number needed to treat of 45. So this, again, is a big deal. I think it's difficult to explain at this point, and the ADA has not quite come out with a firm recommendation related to this. They continued with their algorithm, as I showed you in the very beginning of this presentation, and have just said in the text of their recommendations that we may consider empagliflozin higher than some of the other options because of this finding, but I think it needs to be confirmed and evaluated further. Next, we have our GLP1 agonists listed on this slide. This is a class that I feel like is exploding. There's a number of different options. Some are short-acting, some are long-acting. We have Byetta that's twice a day, and then Victoza once a day, and the others are once a week. The efficacy here is moderate, so we do see a little bit more A1C reduction, especially with the once-weekly versions as compared to the shorter-acting ones than with some of our other classes. And the side effect profile is not bad. There's a low risk of hypoglycemia, and we do see significant weight loss. In fact, there's an agent in this class that has now been approved for weight loss. The cost remains high, though, and so that's another, constant consideration with the new classes of medications. The once-weekly dosing, however, is attractive, and this is really becoming a go-to class for our second-line medication. There's not a lot of new and emerging data here, which based on some of the past new and emerging data could be a good thing, other than what I've mentioned, the Liraglutide or Saxenda brand name has been approved now for weight loss, even in non-diabetics. And the guidelines are now recommending we can consider the addition of a GLP1 to basal insulin prior to considering prandial insulin. Finally, there's a number of new insulin products, and we don't have time today to get into a lot of details, but a few key things that I wanted to point out. The oral inhalation insulin is not doing well in the market. I think historically inhaled insulins have not. So I'm not going to spend a lot of time on that. Just note that it is contraindicated in patients with asthma or COPD. We do have, though, some exciting developments. We have an ultra-long-acting insulin, Degludec, which comes as a single agent or in combination with aspart. And this medication has a half-life of roughly 25 hours, so a clinically effective duration of up to 36 hours and a low peak-trough ratio. So basically, it's peak-less. So we see at steady state a very flat profile. So we have a really, really low incidence of hypoglycemia on this medication if dosed appropriately. We also have a couple of concentrated insulins on the market now, and historically we've had the U500 regular, which has been very difficult from a dosing standpoint because of converting units and such in the syringe. Well, the new concentrated insulins have circumvented that by being put on the market as pens only. So the patient dials up in units, so it's a unit is a unit, so we don't have to worry about converting units. which is nice. So these concentrated insulins are primarily ideal for patients that are on high doses of insulin because we can deliver that same dose in a smaller concentration. Also of note, the glargine U300 or 2JO has been demonstrated to have less hypoglycemia than some of our other marketed agents. I'm going to skip over that. That's from the ADA-EASD statement, and it's just kind of where insulin falls in therapy, which is basically after second-line medication, and sometimes at the point of second line. Because I want to just briefly talk about the pipeline, which is so exciting. We've got a couple of GLP-1s in the pipeline, one that's a short-acting once daily, but one that very excitingly is an oral medication, a once daily oral GLP-1 is in the pipeline. We also have some combination products that I think are really exciting. So a GLP-1 glargine combination, a GLP-1 degludec combination, and then finally an ultra long-acting basal insulin is in the pipeline that would be once weekly dosing, and that's through Novo Nordisk, I believe. And so there's a lot of exciting things coming our way in the near future as it relates to diabetes treatment. Well, that's the end of my official time, and so I'd like to invite anyone that has questions to ask them now, and I thank you for your attention. Okay, well, hearing none, I will close out the webinar, and thank you again for your attention.